We will be placing an episealer in the left ankle of this patient. The patient is supine and the incision is marked on the skin. My finger points at the posterior edge of the medial malleolus and you see the posterior tibial tendon contour. The thumb of my right hand is in the soft spot anterior. After making the skin incision, the fascia is incised and we see the fatty tissue anterior, the fatty tissue between the fascia and the distal tibia. So now in this tissue plane we easily can go to the lateral side and place a Hohmann retractor. After placing the Hohmann, we can enlarge the window if needed. And then we will excise the fatty tissue and the capsule of the ankle joint anteromedial. This is the fatty tissue, which I grab with my pincet. And after removal, we can see the cartilage of the talus. So through this window, we will enlarge it by removing some more of the fatty tissue because we want to see the medial facet of the talus later on. We see a glimpse of the anterior facet of the talus. Because it's important for the preoperative planning, which you see here, the position of the epi-guide in relation to the talus. Then we go posterior, we incise the fascia and the retinaculum, which holds the posterior tibial tendon in place. Carefully dissecting, and when we see the tendon, we will continue dissecting by means of a scissor. Proximal, we have to go quite proximal, which I will show you later on the preoperative planning for the placement of the osteotomy guide, which you see here, and you see that it goes over the edge posterior. That's why we have to release it proximal. This is the level where we will find the ostrigonum, but we will not go in with the respiratorium in that location. We will go more proximal like this and then go on a 45-degree angle pointing distally, and we will follow the contour of the medial malleolus and the talus, which is more inside. So if we carefully follow the bone, we will have the neurovascular bundle posterior, and we can place a Hohmann retractor in order to protect the neurovascular bundle when we are going to make the saw cut later on. So my pincet points at the tip of the medial malleolus. You see that the guide is just 1 centimeter proximal from it, and this window has to be on the tibia. So there's only one position that it will fit. You press it firmly, and then you will secure it with 2 K-wires. There's also 2 holes for the 2 screws that we will place later on to fix the osteotomy, and these are the 2 holes that we pre-drill for these 2 screws that we place later on to fix the medial malleolus. Then we check the depth of the saw if it's correct. There is this device to check if we have the correct saw, and indeed we see that it is the correct saw blade that we're going to use, because the osteotomy guide will protect the saw from going in deeper. We make sure that we protect with the 2 Hohmanns the neurovascular bundle, and now we can just make the saw cut. After removal of the guide, we finish the osteotomy very carefully with an osteotome. Now, by everting the medial malleolus, we can see the posterior joint capsule. We do a release of the posterior joint capsule, and if needed, we can do a release of just very superficial of the deep portion of the deltoid ligament. Not too much, not to create instability, but we can do a small release. This is the loose cartilage of the osteochondral defect. And now I will evert the ankle, first manually, to see how much space we have by having done our releases. And if we're happy, then now we will place 2 K-wires to accommodate the the retractor, the Hintermann spreader. Sometimes it's possible to place it here with the advantage that it holds the medial malleolus everted. But sometimes it's in the way with the epi-guide that we will place later on. And I will show you that later on. Then we will open it already a little, evert the ankle already manually, and place the second K-wire. The holes can accommodate 2.5 millimeter K-wires, but I advise you to use 2 millimeter K-wires. And I will tell you later on why I use 2 millimeter K-wires. You can place the Hintermann up on the front, but it's better to place it posterior, like is now shown. Now we have to place the epi-guide. We need to see the contour of the talus completely, and now we can place it and see if it fits. It has to fit exactly as is shown on the preoperative planning. So if it doesn't, then you have to readjust, in this case, your Hintermann. And you see I replaced the Hintermann in order to make sure that it doesn't block the epi-guide. Now I make sure that the epi-guide is everywhere exactly on the cartilage. There should be no gap. It should be exactly as shown on the preoperative planning. Once I'm happy and I take my time to really place it well, then I will fix it with the 2 K-wires. We bend the K-wires from the Hintermann spreader, and with the 2 millimeter it's possible to bend it, but still the Hintermann spreader will be slightly in the way. I point with my finger that this part of the Hintermann spreader will be in the way, so now I can bend it away, keeping the distraction. We place the centralizer in the epi-guide. The centralizer is just to create a central hole for the drill that we will be using later on. So it's just a central hole. And then we place the first guide. You see the arrow on the guide, and the arrow should point at the corresponding arrow on the epi-guide. And here you see the arrow on the epi-guide, arrow to arrow. And then we take the drill and we will drill the first part, only superficial in the cartilage, but the guide will guide us. Then we, after removal, we place the second guide, and the second guide will be adjustable to go to the correct depth. Arrow to arrow, which means that if we now will drill, and that's what we will do, then we will be exactly at joint level. So if we would place the episealer later on, it should be then exactly at joint level, cartilage level. So that's not how we will have the final position, but we will start by going to this 0 position. So we drill in this 0 position, and now we have to clean, remove all cartilage and bony pieces. If you have a cyst to fill, then you can use this this cancellous bone. So keep it. You see, it's nice cancellous bone, which you can use if you have to fill cysts, for example. Carefully clean it and take care not to damage the edge of the cartilage, the edge of the hole. And now we place the epi-dummy, and the epi-dummy is tailor-made to the patient, so it should exactly fit into the hole. Check it with this arthroscopic probe. It's very handy, and it should be everywhere at 0 level. Anterior, I find it a little bit too proud, maybe 0.4 too proud. So normally now we would go to 0.6 below the level, but we have to add another 0.4. So 0.6 plus 0.4 is 10. So we go to the 10 level. Which means that now if we drill, we will be 10. That means 1 millimeter below the original level. And 1 millimeter means, since we were 0.4 proud, means that we are at the 0.6 level, which is the perfect level. Clean it again, mark the rotation on the cartilage, mark it with a pen. But first we will check if we are now happy with the position, which should be 0.6 below the surface. And you see the black line, and when you see the black line, you're usually okay. We mark the position of the arrow on the cartilage with a pen. And now we will remove one pin of the epi-guide. Then we will remove the epi-guide but leave the other pin there. So if we are not happy with the final position, we can readjust and drill again. We put in because now we can check it much better and check if indeed it is just below the cartilage level. In fact, 0.6 below the cartilage level, and that's what it is. This is then the episealer with the marking in front, and the marking corresponds or should correspond to the marking with the pen on the cartilage, the marking that we made earlier. And this will ensure that we have the correct rotation. Put it in first manually. If you're not happy with rotation, you can still use this cogger to adjust. Very gently press it in, check the rotation as far as it gets, and then finally we will drive it in as is shown. And then we check if we're happy with the position, and indeed it is nicely, slightly below the cartilage level. And then we will, after we checked it, we will remove the Hintermann spreader and we have to secure the medial malleolus. We put in the K-wires. The holes are 2.5, but I use 2 millimeter K-wires. It makes it more easy to bring them in place. And then we find the corresponding holes on the opposite side, which we pre-drilled, as you remember. And we will now give initial compression with this device. Unfortunately, in this case, we only had the too small device available, so we used this sharp pointed instrument to give the initial compression. And then you fix it with either cannulated, or in this case non-cannulated, compression screws. 2 compression screws for the medial malleolus. If you want, you can check with image intensifier at this point the position of the screws, but normally it's not necessary because everything is pre-planned. And if you use a length of 40 millimeter, you should always be okay. Suturing of the subcutaneous layer with Vicryl, followed by suturing of the skin. After treatment is with dorsal slab, 6 weeks plaster cast, or a walker boot. Better a walker boot, because then the patient can go out of the boot to do some exercise once or twice a day for a few minutes.
Once more about, for example, cycling. It's non-weight bearing 6 weeks, but let's say, what do you think about cycling, swimming?
Yes, of course, but she will have a protection. Huh? She will have protection 6 weeks for the osteotomy.
Oh. Okay.
Yeah, so she can go out of the boot to do some exercise during the day, but just to get the motion. So 2 times a day, 5 minutes to do range of motion, and then back to the boot for the first 6 weeks.
Okay. There was a question from audience. What about antibiotics?
Well, basically, there's only antibiotics because there's the implant, so it is perioperative antibiotics, and that's it.
Okay.
Perioperative antibiotics, of course also anticoagulants for the first 6 weeks. And then after 6 weeks we will make an X-ray to check if the osteotomy is nicely healed. And if so, the patient can go out of the boot and do 100% weight bearing without the boot, followed by probably some physiotherapy. And that finishes this presentation of the insertion of a medial episealer for a medial talar osteochondral defect.